بسم الله الرحمن الرحيم. إن شاء الله اليوم راح ناخذ محاضرة بعنوان Evaluation Criteria for Restorations. Of course, our job in operative dentistry is to place direct restorations, including amalgam and composite. Now, after we finish our restoration, we should evaluate the restoration. Is it acceptable, or it need to be replaced, or it need to be repaired? Also, we need to examine the old restoration that the patient have and when we do our clinical examination before doing the treatment plan, and we need to examine those old restoration. Are they good? Do they need any further treatment? Now, for any restoration that we place, there is some properties that we need to take care about. There is some aesthetic properties, and this is very important when we deal with composite. There is functional property for the restoration, and there is biological properties. Now let's start speaking about the aesthetic properties. The first property is the surface roughness, which affects the surface gloss and luster. And surface roughness is a measurement of the texture of the surface of the restoration. معنى آخر هي مدى خشونة السطح للحشو. And this is very important when we are doing composite restoration. As you remember, in the lab, we do our restoration, then we make finishing and finally polishing. So the degree that you make polishing for the restoration will make it less rough, and it will have better gloss and luster. And also, this is also affected by the material you choose. We have different composite material depending on the filler, either microhybrid or nanohybrid or other types, and those materials, they differ in their final polishing surfaces and final roughness. Now, when we need to examine the surface roughness for the restoration, it's better to light off or switch off the light and stay away from the patient at a distance of 60 to 100 centimeters. Then look at the restoration that you have made. It's not always a must that the restoration should be very smooth. It depends on the adjacent enamel, so the best qualitative measurement is to compare your restoration with the adjacent enamel. If the patient has a rough tooth, so there is no idea to make your restoration very smooth compared with the enamel. The restoration should mimic the adjacent enamel in surface roughness. In this way, you can guarantee that your restoration is exactly mimicking the tooth structure that you have placed the restoration on it. بمعنى آخر، المريض، مش كل المرضى بيكون أسنانهم كتير ملسة أو ناعمة من الخارج، فبالتالي الحشوة اللي أنت بتحطها للمريض لازم النعومة تبعتها اللي أنت بتعملها عن طريق البولشنج تكون مساوية لنعومة الجزء من السن المحاوط فيها اللي هي surrounding enamel structure. فما في داعي دائما نعمل good polishing إذا كان السن نفسه في عليه نتوءات أو كان مش أملس. So ideally, surface roughness should approximate that of the enamel. هذه بعض الأمثلة على حشوات انعملت سواء استعملنا البيفل أو ما استعملنا البيفل. لاحظوا كيف الحشوة نفسها اللي احنا حطيناها على السن كثير السيرفس رفنس تبعها أو المنظر تبعها كثير مساوي للإنامل اللي محاوط فيها. So as you can see that the restoration that we placed return the normal anatomy to the structure, and it has the same surface roughness and luster and gloss as to the other adjacent natural teeth. Now the second property in the aesthetic properties is the surface and marginal staining. And marginal staining could be either slight staining or it could be severe staining. The slight staining is defined as being visible on the clinical inspection using mirror and illumination. So you can just see it when you examine the patient. However, severe staining is visible at speaking distance of 60 to 100 centimeters, as you see in this picture. We have a severe staining around the restoration. Now, color change is usually an indication about the sealing properties of the restoration. Why we will have staining or marginal staining around composite. It could be to many reasons. Maybe there is a problem in the placement technique of the restoration. Maybe there is degradation of the margins or fracture of the restoration or fracture of the adjacent enamel. So there will be a small gap, and this gap will allow the plaque accumulation and bacteria there, and this will lead to staining over time. طبعا بالنسبة للحشوات اللي انتم بتحطوها في لحظة في نفس اللحظة صعب نشوف marginal staining. لازم هذا نشوفه في المراحل اللي هي اللاحقة ولما نعمل إعادة تقييم للمريض. So at follow-up stage you might see marginal staining around your restoration. However, we examine these properties for any old restoration that the patient have at the time of clinical examination before treatment planning. Now for slight staining, usually we make repair for the restoration unless there is a recurrent caries, a huge recurrent caries, and for severe staining, usually it's better to replace the restoration. However, there is a lecture that you will take next year, inshallah, about the choices between repair and replacing composite restorations. The third property is the color match or the stability and translucency of your restoration. And of course, this is only applied to composite restoration. At baseline restoration in a visible area of the mouth, mostly anterior restoration should have color match comparable to that of the surrounding tooth structure. So at the time you place your restoration, it's very important to make a good match between the remaining tooth structure and your restoration. And as you remember in the lab, we have different color for the same tooth depending on the area. The cervical area is usually more opaque compared with the incisal area, which is more translucent. So if the restoration that you're placing is very large, the size of the restoration is very large, you might need to use different shade for the different area of the restoration. So it's very important, as you remember when we did class 4 in the lab, if the restoration is very large, it was difficult to have better or a good match if you use the same color of composite. So you need to use different colors of composite in large composite restorations. The fourth property is the anatomical form. The anatomical form of the restoration is evaluated for its effect on the overall aesthetic appearance, and the aesthetic outcome being partly determined by an acceptable form. زي ما بتتذكروا بسنة أولى كتير تعلمتوا على حفر الصابون إنه كيف ترجعوا أو كيف تحصلوا الشكل المناسب للسنترال انسايزر، اللاترال انسايزر، الكيناين. كل سن له شكل معين، فمش منطقي إذا أنا بدي أعمل restoration لانتيريور سنترال انسايزر أعمله مثلا شكل اللاترال انسايزر، أو يكون شكله مختلف عن شكل السن المجاور له من نفس النوع. فكتير مهم الاناتوميكال فورم. راح أوريكم بعض الصور. زي ما انتم شايفين بهاي الصورة في عنا دايستيما، في عنا فراغ بين السنين، لكن إذا أنا بدي أسكر هاي الدايستيما للسن المكسور رح يطلع شكله مختلف عن شكل السن بجنبه، فبالتالي أنا حافظت على الشكل السن وخليت الدايستيما الموجودة بين السنين حتى أحافظ على النورمال anatomical form for the tooth structure. إذا المريض بده هو يسكر الدايستيما لازم أضيف على السنين الرايت والليفت سنترال انسايزر حتى أسكر هاي الدايستيما بحيث أحافظ على الشكل المناسب لهم، اثنين يكونوا نفس الشكل. المثال الثاني نفس الشيء، شايفين في عنا large diastema. We try to keep that diastema as it is and we place our restoration to mimic our anatomical form for the both central incisors. المثال اللي بعده بتشوفوا إنه ما عنا دايستيما، لكن زي ما أنتم شايفين أي restoration أنت بتعملها ل two adjacent teeth you should mimic the normal anatomical form of the adjacent tooth from the same type of teeth. برضو هون بعض الأمثلة الأخرى شايفين قديش في عنا تناسق ما بين شكل ال right وال left central incisor when we did our restoration. يمكن الخط الثاني بالنص إذا شايفين في عنا شوية ال central incisor أطول من الثاني، ففي هاي الحالة لازم تعمل trimming له حتى تضبط الشكل تبعه. وهيك بكون خلصنا حكي عن ال aesthetic properties of the restoration. نحكي عن ال functional properties. أول إشي لازم ننتبه إله اللي هو fracture of restorative material and restoration retention. طبعا هذا منطبق حاليا على النوعين سواء amalgam أو composite restoration. برضو على ال indirect restoration هاي كل هالproperties لازم تنطبق. So fracture of restorative material لازم تطلع على الحشوة إنه ما يكون فيها أي كسر. Restoration should be present with no fracture, cracks or shipping. إذا في عنا fracture في عنا secondary caries. إذا في عنا part of the restoration is missing or part of the tooth structure is missing, we should record this and make our further examination. Also, marginal adaptation. Now, the most important property of marginal adaptation is no presence of any gap. And we can examine this with the use of a probe, a blunt probe. We make the probe passing between the restoration and the margin of the tooth structure. If we have any gap, then the probe will drop in an opening. And we call this opening is a marginal gap. And sometimes they call it ditching, and it's the deterioration of the amalgam tooth interface as a result of either enamel fracture by improper tooth preparation or wear, or sometimes restoration edge fracture. زي ما انتم متذكرين كان في عنا شيء اسمه resistance form for the cavity preparation. إذا كان عنا مشاكل بالresistance form بصير في عنا fracture إما بالtooth structure أو بالrestoration نفسها. هذا الفراكشر هو اللي بيعمل لك المارجنال جاب، فبصير عنا ditching بالسيرفس وبصير في عنا مشاكل طبعا. بعدين رح يصير عنا recurrent caries إذا ما عملنا good treatment أو good repair or good replacement for the restoration. Now, depending on the size of the gap, we will decide either to replace or to repair the restoration. Usually in shallow ditching less than 0.5 millimeter deep, usually it's not a reason to replace the restoration because it's a self-cleaning area, and you can just recontour the enamel or repair the fracture area with a small restoration. However, in deep ditch, it will jeopardize the integrity of the remaining restoration, and it's better to replace all the restoration. Sometimes if the marginal gap or ditching is near the gingival wall, it's difficult to clean for the patient, and usually this restoration is considered failed restoration and it needs to be replaced. Now, after we check the marginal gap to confirm the marginal adaptation, we should also examine the marginal morphology. Now, marginal morphology is very important for indirect restoration. As you see in this picture, that we have a problem in the root caries under a crown preparation. Now, the morphology of the margin is very important in direct restoration, and you will learn next year about the type of finish line, either chamfer, shoulder, or combined, and this morphology of the finish line or the margin should be suitable for the material you use. If you use, for example, ceramic crowns, the finish line should be different than using metal crowns. So marginal morphology is of special interest for all restoration and particularly for indirect restoration. If you have problem in the morphology or there's no adaptation between your crown and the morphology of the finish line that you made, you might end up with secondary caries. As you see in this picture, we have root caries under the crown. Now, this root caries is sometimes very difficult, and you might need to extract the tooth because you can't treat those hidden areas. Also, for margin adaptation, we need to check for overfilling or underfilling. I think all of you work with composite and amalgam in the lab, and you remember we call when you did your amalgam, sometimes we told you that this is overfilled or underfilled restoration. So overfilling and underfilling must be specially assessed during the baseline evaluation. Now, we usually carry our probe and pass the probe from the tooth structure to the composite. And I told you, if you pass the probe from the tooth structure and you have resistance to move to the amalgam, for example, or the composite, then your margin is overfilled. If you pass the probe from the tooth structure to the restoration and you feel that there is a drop, then you have underfilled restoration. The probe should pass passively and smoothly over the two margins to say that this margin is ideal. Now, in case of composite, if you have underfilled, you can refill it. And if you have overfilled, you can trim it with the finishing and polishing burrs. However, for amalgam, it's sometimes difficult to do that. The defect, if it's very small underfill in the amalgam, it's acceptable clinically and can cause no long-term problem. However, if the defect or underfilling in amalgam is very severe and all your margin is exposed, then you need to replace this amalgam. For overfilling of amalgam, if it's very minimal, you can refer the patient or delay the treatment for 24 hours, and then you will bring the patient and correct the overfilling. Now, if all the restoration is very high and the patient can't or the patient bite on only your restoration, it's better to remove the restoration immediately and place another one at the same time. Underfilling might be easier for the patient to withstand. يعني المريض ما بيكون في عنده مشاكل إذا كانت الريستوريشن underfilled، بس إذا كانت الريستوريشن overfilled راح يصير في عنده مشاكل في الإطباق الموجود عنده، فراح كتير يحكي لك في مثلا مش قادرة أعض على أسناني، أو بعد فترة إذا بيروح والريستوريشن كتير عالية راح يرجع لك في مشاكل في الفك. So try your best to make you sure that your restoration is not overfilled or underfilled at the same time of placement. Now let's speak about another functional properties, marginal deterioration. We speak about ditching in a few minutes. Ditching previously discussed, it's the fracture of enamel or restoration due to different reasons, as we say before. However, there is something else called chemical degradation that lead to marginal deterioration. Now, chemical degradation doesn't have any relation with mechanical properties of the restoration or the tooth structure. It's related to the restoration itself. So there is some degradation of the material of the restoration that you use. So degradation of, for example, the polymer part or polymer matrix of composite, detachment between the filler and matrix of composite, sometimes interaction between the amalgam component and the environment around it. All of those we consider them as chemical degradation that will lead to irregularity of the restorative material, which result in tooth sensitivity and decreased surface smoothness. So the surface starts smooth, then it will become rough over time as a result of chemical interaction of the restoration with the oral environment. Now, usually if you diagnose a marginal deterioration because of chemical interaction with the oral environment, usually this material will fail in the future. So it's very important to know the material that you are using in your lab, in your clinic, and it's better to use the material that has a good properties, good wear resistance, doesn't have interaction with the tooth structure, doesn't have interaction with the oral environment, and doesn't have chemical degradation. And it's better to follow up those restoration over time to see any problem. You can correct it immediately and don't wait until failure happens. As you see in this picture, this is an existing amalgam restoration that exhibit marginal deterioration and surface roughness. Now the treatment was to just repolish the surface and make it more smooth, and then you will follow up this restoration. In case any failure happened, then you will replace it later. Also about functional properties is wear. Wear is a physical phenomena as a result of occluding with opposing surfaces, leading to the loss of the restorative material. For example, if your occlusal surface is made from composite and it occludes with natural to the structure, usually composite has a low wear resistance, so it will wear with over time. So if you make your restoration with normal function, normal shape, normal anatomy with cusps and fossa, marginal ridges, after a while, the wear will make your restoration flat and it will lose its functional properties. That's why it's very important to decide which material you will choose in a heavy occlusion area. Also, the wear is not always happen on the occlusal surface. It also might happen on the proximal surface. So when you use composite for posterior teeth, you might, for example, build your contacts well at the time of a placement of the restoration. However, at follow-up stage, you might feel that the restoration has an open contact, and this is due to wear of the restoration at the proximal surface. So we should make differential diagnosis or differentiation between the occlusal contact area and the contact-free area where you will have also wear at the smooth surfaces that doesn't have any occlusion. As you remember, when we speak about using composite in complex restoration, usually we have a problem in using composite when we have large occlusal surface to be restored with the restoration. So in those cases, maybe it's better to use either indirect restoration or use amalgam restoration instead of composites. Also, wear make a problem when you dealing with indirect restoration, like for example when you have a ceramic crown occluding against natural teeth. Now the ceramic is is more tough than the tooth structure, so the wear will not be on the ceramic itself; it will be on the natural teeth. So you'll have more wear on the natural teeth. So it's very important to choose your material and follow up the patient to prevent any further wear of either the opposing dentition or the restorative material that you are using. Also, one of the functional properties is the proximal contact. Now, the proximal surface of a restoration should recreate the normal high of contour such that it comes into contact with the adjacent tooth at the proper occlusogingival and faciolingual area with correct adjacent embrasure form. And as you remember, we use matrices for this purpose, and we should adapt our matrix to the adjacent tooth and place wedges, all of those to create a good proximal contact. And remember, we place the wedge to compensate for the thickness of the matrix that we use, so we will not end up with open matrix. So all of those procedure was very important to have a proximal contact. An appropriate degree of contact is necessary to prevent food impaction. Now, if we have food impaction, then we will end up with secondary caries and gingival problem. Those of biological width, all of those will happen if we have open contact. Now, how we will examine the proximal surface? Usually we examine the restoration with a blunt explorer and with a 50 micrometer tip, and sometimes we use the wax dental floss. You will place the wax between the two teeth, and there should be some snap or some resistance when you remove your waxed dental floss. Now we should have, as I say, a snap effect. When you place your floss and remove it, there should be some resistance. We call it snap effect. This indicates that you have a good proximal contact. If you don't have this snap effect, so most likely you have open contact. Sometimes we use some metal matrices strips. We call them shim stocks. They come in different thickness, like 25, 50, or 100 micron, and you can use them between the two surfaces. You can pass them, and then you can decide exactly what's the width of the contact that you have. For example, we need 25 micrometers. Or 50 micrometer is acceptable for an ideal contact, so you can use this thickness to examine the contact, and it will give you better conclusion about the contact, better than the floss material. So again, if you have an open contact, you don't have the snap effect of floss, or use the shim stock, and it's indicate more than 50 to 100 micrometer opening, it's better to replace the restoration or repair it depending on the restorative material that you are using. If the open contact is not corrected, then you will have food accumulation problem in the gingival tissue, and it will be annoying for the patient. So you need to treat it immediately. Now finally we'll speak about the occlusal contacts. Now, occlusal contact is very important because any improper contact will make or have deleterious effect on loading, and this will might make a fracture of the restoration, fracture of the tooth structure, or sometimes the patient will have pain on biting. We call this hyperocclusion. The patient will come after a week, for example, having a pain and he can't bite on his tooth. So it's very important to check your occlusion after you finish your restoration. And you can check this with either ask the patient to bite and you will find shiny surfaces on amalgam, or you can use the articulating paper. Those papers come with two different colors, and you can place them between the teeth and ask the patient to bite, and then you will have a mark at the area that is high in occlusion. After you defined your area of high occlusion, then you can trim it with the pairs that are available in the clinic. If you remember in amalgam, we told you that it's better not to use rotary instrument when you are dealing with amalgam. So if you have high contact in amalgam, try your best to remove it with carver and delay any further treatment after 24 hours. For composite, you can immediately remove the high contact and make your final polish. As you see in this picture, we have occluding restoration. We have heavy occlusal contact on new amalgam, and it's marked with dark color from the articulating paper, and the amalgam was carved out to remove this high point. And if the material is hard with you, try your best to remove the high contact as much as possible, and any further treatment should be delayed for 24 hours. Now, the best indication for the functional properties of any restoration you place for the patient is the patient satisfaction with the restoration. It's the patient perception with regard to aesthetic, showing comfort, pain, hypersensitivity, ease of ability to clean the restoration with toothbrush or a floss, and gingival bleeding or any other problems such as detection of the restoration with the tongue. All of those are very important to ask the patient about at the time of placement and also at the follow-up stage. مدى ارتياح المريض في الحشوة اللي انت حطيت له اياها بيدل على تحقيق الفانكشنال بروبرتيز للريستوريشن تبعته. فإذا كان المريض مش مرتاح لأي شيء من هدول الأشياء اللي ذكرناها، معناته في عنا مشكلة بالفانكشنال بروبرتيز للريستوريشن. So always ask the patient after you place your restoration about all those factors, all those things, and at the follow-up also ask them if he have any problem. Now the last properties we'll speak about is the biological properties. The first one is post-operative hypersensitivity and tooth vitality. Now post-operative hypersensitivity, we should record it for each tooth at the time of restoration, at the baseline, and at all call visits. And it can include type of pain, the discomfort, the duration on stimulus at all clinical assessments. Now this means when the patient come to your clinic at baseline, you will record any symptoms in the tooth that you will treat, and you call this the baseline. For example, patient came to your clinic and tell you that he has a pain in lower molar when he eat sweet or drink cold water. So this is the baseline hypersensitivity record. After we place our restoration also, we will ask the patient if he have any problem when he drink, for example, cold water, or we sometimes place some air around the restoration and ask the patient how does he feel and if there is any discomfort. Also, we'll give the patient a time to examine or use this restoration, and then at recall visit we will ask him again about any pain or discomfort and duration that he will have and what is the provoking factors for this pain. Now, if he has pain in the tooth before we treat it, and this pain continue after we restore this tooth, for example, for almost 2 weeks, this we call it post-operative sensitivity, and it's normal after placement of our restoration, especially with amalgam. Amalgam need time to self-occlude the spaces between the tooth structure and the restoration and render the restoration self-sealing. Sometimes also with composite, if you don't use good lining material or you have defective bonding on certain spaces, you will have open margin and exposed dentine, and according to hydrodynamic theory, you will have some discomfort after placement of the restoration. Now, post-operative pain, if it's transient pain, this is normal for 2 weeks to up to 1 month, and it will subside by itself, and it's acceptable. The patient doesn't need any further treatment. However, if we have persistent pain after we place our restoration, this indicates that there is a problem in the bulb and it might need intervention, either to remove the restoration, replace it if there is any defect in the margins, or sometimes if there is a problem in the bulb, you might need to do RCT treatment. Now, recurrence of initial pathology. As we say, we deal with dental caries, and this dental caries has many etiological factors. We might place our restoration if there is any defect in the design or a defect in the restoration, or the patient continue doing his previous eating, same diet, doesn't clean his teeth, then we will have a recurrent caries around the restoration that we have placed. Now we need to examine this recurrent of pathology. If it's dental caries and we can manage it by repairing the same restoration, you can do that. If we have large caries, then we need to replace this restoration with a larger one. If we still have erosion or abstraction around this restoration, we should actually modify the etiological factor and then retreat the tooth structure. Now, it's very important in our work to work on the etiological factor. Dental caries and erosion, abrasion, all caries and non-carious lesions, they have some etiological factors. If we don't modify those factors and the patient stay on the same routine of his life in diet and cleaning of his teeth, then you will end up with recurrence of initial pathology. So it's very important to modify your etiological factor, then you do your treatment. Now the third one is tooth crack and fracture, and we mentioned this in the functional properties. This is also important for biology. It has biology. It's one of the biological properties because any crack or fracture, it will render the surface able to collect plaque or accumulate plaque, and this will affect the biology or the periodontium and gingival health around the tooth structure. That's why we mentioned the tooth crack and fracture in this area, and any crack or fracture should be examined. If we have a slight crack, it might be possible to repair it or correct it. Sometimes enamel crack are acceptable. They occur normally on the tooth structure. A slight fracture, you might repair it. However, if you have deep fracture or large fracture of a restoration, it's better to remove this restoration and place another one. This is considered an acceptable restoration if it has a large fracture. Now, effect of the restoration on the periodontium. The restoration you place should have no inflammation of the papilla, and it should have no overhang. If you have overhang, then as we say, it will affect the gingival health, food accumulation, then we will have loss of bone, and then we will end up with periodontitis around the tooth. So it's very important to examine your restoration for overhangs and the contour, and make sure that there is nothing that will affect the periodontium. And finally, any localized reaction of soft tissue in direct contact with the restoration should be examined. Now, if we place our restoration and then on follow-up we found that there is, the mucosa adjacent to the restoration has sign of allergic reaction like mild or severe redness, sometimes the swelling or liconoid reaction, or any other signs of allergy, then we need to remove this restoration and replace it with another type. So it's very important to examine the reaction to your restoration at follow-up stages. And finally, after we know all the properties that we need to check for each old and new restoration, we should know that the environment required for evaluation should have always a clean, dry, and well lit filed. And you need to use visual observation and the application of tactile sensing using a blunt explorer. For vision, if you have problem in your vision, you might use loops or any other magnification instruments. And then you should examine the tooth from all the surfaces with a careful examination with the blunt probe. And sometimes we need some adjunct methods for diagnosis. We might need radiographic examination. Radiograph of restoration may give valuable information with regard to gaps, secondary caries, overhang, steps, underfilling, and the level of alveolar bone. So it's very important to take x-rays. However, we should take those x-rays if clinically indicated. For example, as you see in this picture, we have a failed restoration. So we find clinically that we have failed restoration. After we confirm that we have a problem, then we will take our x-ray. And as you see in this example, we have a crack or we have a fractured line in amalgam. So we have a problem with the amalgam, then we decide to take the x-ray, and then we find that there is a fracture and there is separate to amalgam restoration. And after that, we will decide our treatment. Another example here, it shows you that there is an overhang. So the patient came, for example, to your clinic. He has a problem in the gingiva. He has discomfort when he bites on those teeth. You find that there is bleeding from the gum. So we have a problem clinically. Then we will decide to take the x-ray. The x-ray revealed that there is an overhang. Now the treatment plan will be to remove this overhang, and then we'll follow up the tooth to see if the symptoms will be gone. I hope that you have useful information in this lecture. If you have any question, please send me an email. Inshallah, I will respond as soon as possible. Good luck.